All right, welcome everybody. Welcome to Life in the ER PA edition. I'm Carol, and I'm a practicing PA in an ER at a level 1 trauma center. Today we're going to be talking about acute limb ischemia, episode 1 of Book to Bedside. So I've only had a couple cases of this, but whenever I do, it's not always obvious at first until it does become obvious. So acute limb ischemia, by definition, is like a sudden decrease in arterial blood flow, tissue hyperperfusion, which is not great. It leads to critical limb ischemia. Risk factors for this: smoking, diabetes, probably the biggest one, the biggest two, diabetes and smoking, hypertension, hyperlipidemia, an increase of homocysteine, which is a great vascular risk because it's basically like an abnormal mechanism of amino acids. Increase in CRP, which is just a marker of inflammation, often signaling like an underlying vascular type pathology. Common arteries that are occluded or decreased in arterial flow of these arteries, like the most common ones are the femoral popliteal, then the tibial, then the aortoiliac, then the brachiocephalic. Now, generally, once you have an acute limb, you have about a 25% one-year mortality, unfortunately. Many also require amputation in the end for their peripheral arterial disease. So you get irreversible nerve damage within about 4 to 6 hours-ish if you don't have collaterals. Which are like different blood vessels that can eventually start to supply the rest of the limb. You can get a lot of complications with this. For example, once you get your acute limb treated, you can get like a reperfusion injury, which can be like compartment syndrome, rhabdo, which, as we all know, is the breakdown of skeletal muscle fibers, which causes a release of like myoglobin and CK and potassium and other intracellular contents into the bloodstream. You can get hyperkalemic. You can get some acidosis. A lot of different metabolic abnormalities happen, which can ultimately lead to death. And you get about 1/3 of deaths from actually a reperfusion injury, metabolic complications of the reperfusion injury. Now, what is the most common cause is like a thrombosis. Greater than 80% of lower limb ischemia is usually like on some sort of like a PAD graft or something. But just to kind of lighten up the mood a little bit, like, why did the thrombus break up with the embolus? Because it felt the relationship was going downstream. That is an unfortunate joke, but but it's still kind of funny in a not funny episode. So an embolism, usually from like a cardiac cause, like AFib, like a mural thrombus from like your heart valves or something like that. And then other causes could be like intra-arterial drug injections, prolonged vasopressors, or like an aortic dissection. And of course, your lower limb ischemia is a lot more common than your upper limb. The most common cause of the arterial embolus, again, is from like AFib or like a recent MI or valvular heart disease. And arterial thrombosis is most common at like the level of like your subclavian or the axillary artery as well, due to atherosclerosis or arteritis or like a thoracic outlet syndrome. Other risk factors could include like heart cath complications, blue toe syndrome, vasculitis can cause this, RA, lupus, polyarteritis nodosa, Raynaud's, Takasuyu's arteritis, HIV even, hypothermia hammer syndrome, popliteal aneurysms, etc., etc. So in general, it's super hard to tell the difference between like if the cause is from an embolism or a thrombosis. But in general, you can tell by just like a kind of couple different things. So if you have like a history of claudication, you're looking probably at more of like a thrombosis than an embolism. If you have signs of arterial disease on both legs, you're looking at a thrombosis. Whereas if you have like one limb that is normal versus one that is not normal, that could be more of like an embolism. If you have like an identified source, like an obvious source, it could be your embolism. More sudden, like you know exactly when something happened, like boom, there it is probably more of an embolism type picture, whereas more gradual is generally thrombosis. And then if you have like a sudden abrupt cutoff of your blood vessels or blood flow with no collaterals, it's more of an embolism. Whereas if you have collaterals and there's like widespread disease and it's obvious it's been going on for a hot minute, you're looking at more of a thrombosis. So super important to think about other differentials in the emergency department, like whenever somebody comes in with, for let's say like acute leg pain, you're going to want to think about like your vindicates. So V for vascular, I for infectious or inflammatory, N for neoplastic, D for degenerative or deficiency, I for iatrogenic or intoxication, C for congenital, A for autoimmune or allergic, T for traumatic, E for endocrine or metabolic, and S for structure. Obviously, this is a vascular case, so you're going to want to automatically be thinking about some sort of arterial thrombosis or embolism. You want to be thinking about an aortic dissection, some sort of like a DVT or something, vasospasm. For infectious or inflammatory, you could be thinking about some sort of arteritis or vasculitis. Obviously, you want to be thinking about like a neck fash or cellulitis as well. For neoplastic, you can think about like a compression by some sort of mass or something, or like a tumor embolus. For degenerative or deficiency, you can think about severe atherosclerosis, vitamin deficiencies, which can cause different types of things, like B12 deficiency, for example, as B12 can cause, like paresthesias and weakness and leg pain, burning, tingling, heaviness, that type of thing as well. Iatrogenic or intoxication, you can think about intra-arterial drug injection. You can think about some sort of procedural injury, like if you just had like a heart cath, an art line placement, something like that. You can think about, for congenital, you can think about like some sort of congenital vascular malformation, or like a PFO or an ASD causing some sort of emboli. For autoimmune or allergic, you can think about like a hypersensitivity vasculitis or an antiphospholipid antibody syndrome. For traumatic, obviously compartment syndrome, or fall or fracture or dislocation or something. Endocrine and metabolic, you could think about diabetes, which can cause PAD, microvascular injuries and occlusions, which could then cause critical limb ischemia. You can think about hyperthyroidism, which could increase like your risk of AFib and things, causing embolic events. Hypercoagulable state could be secondary to malignancy or other things. Structural, you can think about like thoracic outlet syndrome, subclavian artery compression, popliteal artery entrapment. You can have aneurysms. You can get, there's tons of different things that you can talk about using the Vindicates method for your differentials. For critical limb ischemia, your clinical features and your exam, you're going to want to memorize the 6 P's: pain, pallor, pulselessness, paresthesias, paralysis, and poikilothermia for cold. For early signs, you can get like a severe pain, you can get sensory changes, and some weakness. More late findings, you can start to get skin changes, like you can see obvious skin changes like skin color changes, necrosis, blisters, mottling, petechiae, fat necrosis, gangrene, cyanosis. Super earliest finding might be just pain at rest. So another joke here. What did one ischemic leg say to the other? You're really cramping my style. So when you see one of these patients, make sure you do, obviously you want to do a great neuro exam. You're going to make sure that they have equal strength, equal sensation. Obviously you're going to check some pulses. If you're having trouble finding some pulses, make sure you pull out that Doppler and try to listen for a pulse or some sort of signal. For your neuro exam, if you want to get super nitty gritty, you can do like a 2-point discrimination. You can do vibratory sense, proprioception, and see if any of that is diminished. You can also get super specific about like the pain sites if you really wanted to. In general, like it's kind of generalized, but if you're having claudication or pain at the buttocks, the thigh, sometimes the calf, you could be looking at an iliac artery involvement. If you have pain mostly at the thigh, you could be looking at a common femoral artery involvement. Upper 2/3 of the calf, you could be looking at superficial femoral artery. Lower third of the calf, you could be looking at popliteal artery. And then if you're having problems with the foot, you could be looking at it for popliteal or tibial or peroneal artery involvement. So very important criteria called the Rutherford criteria is you're going to want to take this criteria to show you kind of how far along, I guess, or how severe this acute limb is. Category 1 being viable, not immediately threatened, no severe sensory loss or weakness. You have an audible arterial Doppler signal, and you also have venous signals. For threatened is category 2. It's A, marginally, and B, immediately. Marginally is like salvageable if you get like very prompt treatment. You can get minimal sensory loss, no muscle weakness. You do not have an arterial Doppler. For immediately, category 2B, immediately, you have a salvageable with immediate revascularization, like you get in the OR right now. So you're going to have sensory loss more to the toes associated with rest pain, mild, moderate muscle weakness. You're not going to have an arterial Doppler. For category 3, which is irreversible damage, you're going to have major tissue loss or permanent nerve damage. You're going to have a profound sensory loss. You're going to have profound muscle weakness, paralysis. You're not going to be able to hear arterial or venous Doppler signals. So how do you diagnose this? Well, obviously, you're not going to have Doppler signals. You want to go by your 6 Ps. You get your history, like do they have a history of AFib or a recent MI, or do they have like a known PAD with graphs? You can be looking at AFib for like an embolus or a known PAD or graphs for like a thrombosis type picture. Obviously, you want your Doppler signals. You want to compare pulses. You can do ABI if you need to. For your labs, you want like a CBC, BMP, basic electrolytes. You want a CK, lactate. You can do myoglobin if you want, coags. Obviously, you can do like an EKG if they have a history of AFib, or just in general, you're going to want that. For imaging, you're going to get a duplex. You can do either like a CTA or an MRI, but you want the angio for that. And so what are you going to do in the emergency department the second that you think that you have an acute limb? You're going to call vascular immediately. Vascular is going to come in. They're going to take a look at this imaging. They're going to assess your patient, and they may take them back immediately for revascularization. Another thing that you want to do pretty emergently is some IV heparin. Your IV heparin is going to be at 80 units per kilogram bolus, followed by 18 units per kilogram per hour. This is going to prevent your clot extension, recurrent embolization, venous thrombosis. It's going to prevent microthrombi distal to the obstruction and reocclusion after reperfusion injury. Obviously, you're going to want to do some pain meds because your patient's going to be probably crying out in pain, saying, "What the heck is wrong with me?" And then one more joke for you guys. What's the favorite dance move of a vascular surgeon? The stent step. But yeah, your vascular surgeon's going to be obviously like the home run person here. Like they're going to be the one to take this patient. Your patient is not going to go home for maybe at least a couple days. They're most likely probably going to get revascularized in the OR unless there's some like obvious contraindication. I mean, obviously if they can't be revascularized, they're going to lose this limb. So like they're going to end up in the OR eventually, either way. But you're going to want to do catheter-directed thrombolysis. This is going to be your vascular surgeon like taking charge of this, but you can do like a thrombolysis. You can do a mechanical thromboembolectomy, You can revise like a previously occluded bypass graft, or you can put in a bypass graft, and things of that nature. Again, your vascular surgeon is going to be the expert to talk to about all of that. In the ER, our main focus is we're going to call that vascular surgeon. We're going to start a heparin drip, and we're going to monitor their pain levels. While you're waiting for that vascular surgeon, you could also start to think about, well, okay, now that we have the cause of this patient's pain, we know we have an acute limb. Now, why do we have that acute limb? So you want to make sure you take a really good history and you do a very good physical. You want to focus on the leg at first. Obviously, you're going to be focused on the leg at first, but then you need to look elsewhere and be like, okay, am I missing an aortic dissection that's happening right now? Do I need to be like doing other things? So you need to figure out what's causing this, and then if there is something that you can do in the emergency department setting to help at that moment. Obviously, you do not want to miss an aortic dissection. For upper limb, for upper extremity, you can consider like excision of the first rib, the cervical ribs, fibromuscular bands for like thoracic outlet syndrome and things of that nature as well in terms of treatment plan. For long term, you're going to want to do smoking cessation. Don't let them touch a cigarette ever again. You're going to want to exercise, and they might go home on aspirin or Plavix or both. So 1 year mortality is about 25% outcomes and complications for these folks, and approximately 25% of folks require amputation. About 1/3 of deaths are secondary to complications due to metabolic complications after revascularization. So you can get tons of different types of reperfusion injuries can occur. You can get compartment syndrome, rhabdo, metabolic abnormalities, etc. So obviously, if you're a disposition, like they're going to the vascular surgical team, and hopefully that you will hopefully not see them again, and they will be gone from the emergency department very quickly as a level 1 to the OR. Obviously, if you do not have vascular surgery in your hospital or in your ER, you're going to have to transfer these people out as soon as possible. So now that we know all about that information, I wanted to talk about like a real life case in the ER that we had maybe a couple years back in my ER. And this was actually my patient. So now that we talked about acute limbs, I wanted to talk about a real life case. So let's say there's this patient in his 50s or 60s. He's presenting with lower extremity pain and weakness. It's been kind of gradual worsening over the past week. He was initially seen in the ER yesterday. Let's say that we're seeing him today. He was initially seen in the ER yesterday. He was a stroke activation with a negative CT and MRI imaging because he had, let's say, left lower extremity weakness, and he also had some pain. He was stroke activated with a negative imaging. Neuro wasn't impressed. They're like, this is not a stroke. This is not a TIA. Something else is going on. But at that point, you didn't really have it, and he's coming in saying that he has no medical problems at all. Well, you find out later, plot twist, that was not true. You can never trust your patients in the ER when they tell you that they have never had any problems at all with their health. You just cannot trust these people. They're 99% of the time they are not being truthful, or they just don't realize that they're not being truthful. They don't realize that it's a medical problem or whatever. So let's say he didn't have any other symptoms at that point. He was discharged with very strict return precautions. Hey, if this gets worse or any change or whatever, come back. So let's say he comes back today to the ER with worsening pain, but now he's having some right lower quadrant pain in addition to worsening, let's say, right lower extremity pain. I think I said left earlier. Let's say he's got right lower extremity pain and weakness, and now it's worse. Well, this time, now we're trying to rule out like an acute appendicitis. So we did a CT. Let's say we do a CT abdomen pelvis. It shows occlusion of a major artery going to his right leg, the common iliac. Well, then we did a CTA, and then we did runoffs all the way down, and that just shows, again, common iliac occlusion. So then what do you want to do? Well, did you hear anything about checking the pulses or anything at the beginning of this case? No, you did not, because let's say that the ER team Did not check that. So the second your patient gets back, first of all, you're going to call vascular and call them. So they're going to be at the bedside as the patient's coming back, and you're all going to assess the patient together because you didn't check for this. So he gets, let's say the patient gets back, there's no pulse. His right leg, we're talking about right. Yes, the right leg it's starting to turn colors. It's getting pale. He can't move his toes, and he's got no pulse. Well, it turns out he had the 6 Ps. So now it's vascular's turn to play in this scenario, and they're going to take the patient back. But in the meantime, before they can go, you start a heparin drip. So lessons to learn about that, about this case so far, is in a stroke activation, you're having lower extremity weakness and pain. Generally, when you're having a stroke, you're not in pain. You can't feel anything. So you're always make sure you do a very thorough physical exam. If they're coming in with leg pain, you need to look at the skin. You need to check the pulses. If you can't really tell the pulses, get your Doppler out. I mean, you need to be looking everywhere. You need to be pressing on the patient. You need to be checking everywhere. You want to look at, a system above and below or a joint above and below, kind of how we're taught in school, and make sure that you're not missing something. You also want to frequently reevaluate your patient because it's possible that the team did check these things and they just didn't document it or whatever, and you are the next person to see the patient. You want to make sure you do frequently reevaluate your patient and make sure that there is no change. You need to be doing this in the ER at least every couple of hours to make sure that there's no change in the patient's clinical condition. Never underestimate the power of looking at the skin and checking some pulses, folks. So now let's say he goes back, he's admitted to the vascular surgery team. Let's say he goes to the surgery and he gets an arteriotomy and an open embolectomy, and he experiences complication of compartment syndrome. He's in the hospital for a few days. He ends up getting compartment syndrome with a lot of metabolic complications. He has to get fasciotomies twice, and then he is eventually discharged on Xarelto or Eliquis or Plavix or aspirin or some sort of combination of all these things. And then you tell that man, don't ever touch a cigarette again. So then eventually you end up learning after he leaves your service that he has a history of PAD, he had a history of AFib, and he had a history of CHF and COPD, and he smoked 3 packs per day. This is a very, very common type of patient scenario kind of situation that we see, not necessarily the case itself being acute limb, but in general, like you see all sorts of patients coming in saying they have no prior medical conditions and they have like a whole laundry list and they're on like a billion meds and they just don't take them or whatever. And this patient in particular had all sorts of things that could help to contribute to this acute limb. So, all right, guys. So that is Life in the ER PA edition. I hope you learned a lot in this acute limb episode. The lessons learned: stroke activations, not always what they seem. Always do a thorough exam. Never underestimate the power of skin and pulses, and frequently reevaluate your patients. And hope to see you next time. Let me know down in the comments if you are particularly interested in a specific topic, and I'll put something together for you.